My name is Allison Jayawira, and I'm one of the Psychogeriatric Resource Consultants at SGS. Before we start, I'd like to review some Zoom etiquette. Please ensure that your microphone, located at the bottom left corner of your screen, is on mute during the presentation. In the bottom center of the screen is the chat box, where you can type any questions or comments. We will be monitoring the chat box throughout the presentation and will allow for some questions at the end. Please note that we are recording this presentation, which will then be accessible through the NSM-SGS website. This week is Mental Health Awareness Week. We have been providing sessions each day this week in an effort to bring awareness to confinement syndrome. NSM-SGS has been shining the light on confinement syndrome, which started with a communique in August of this year. Confinement syndrome is a term coined by SGS in response to the experiences of older adults and caregivers during COVID-19 pandemic. Confinement syndrome reflects a constellation of clinical issues that can be linked to isolation and loneliness during COVID-19. It gives me great pleasure to introduce our next speaker for our fifth and final part of the Confinement Syndrome series, Dr. Kevin Young, physician lead with NSM-SGS and one of our area's few geriatricians. Dr. Young will be speaking on malnutrition and dehydration and the older adult, highlighting how it relates to confinement syndrome. Welcome, Dr. Young.
Thanks very much, Allison, and nice to see lots of familiar names here, and really an honor to participate in what I think is a great week of education around confinement syndrome and some of the things that we see as a result of confinement syndrome. And obviously a very timely topic as we're all sort of watching the numbers go up with COVID, and today sort of setting new records yet again. So hopefully through this second wave of COVID, we can be a little bit more diligent in terms of, as a system, in terms of, making sure that we're aware of some of the harms that are caused by, the decisions that we make with regards to prevention control and infection control, and that we can sort of be mindful of some of the other things that happen to patients. So we're going to talk a little bit about malnutrition and dehydration. Most of this data is just in general and not specific to COVID, although there's been multiple reports around, how important this topic has been in COVID, but much of that research is still being done, and I think we'll be learning lots about the impacts that this has had for many years to come. So the objectives today are to understand how to recognize, diagnose, and/or screen for malnutrition, to understand some factors that can lead to malnutrition, to be able to develop a treatment plan for malnutrition, since most of it is non-pharmacologic anyway, and so all of us can do it, and all of us play a very important role in it. And lastly, to be able to recognize and to treat dehydration as a separate topic. So what are the diagnostic criteria for malnutrition? Well, there's the traditional ones, and these are the ones that most of us learned when we were going through our training. So 2 or more of the following 6, so insufficient energy intakes, in other words, not eating enough, weight loss, loss of muscle mass, loss of subcutaneous fat, which is separate from muscle mass, and you look for it in different areas of the body. Localized or generalized fluid accumulation that may mask weight loss. So sometimes we end up with patients that, in fact, their weight is going up, but it's because their protein or their albumin is going down and they're retaining fluid, or they have heart failure or liver failure or kidney failure and they're retaining fluid, and so therefore they might actually be losing mass, and they may be malnourished, even though their weight is going up. And then lastly, diminished functional status as measured by hand grip strength. So those are the traditional criteria that many of us have heard lots of times. There was some new criteria which the Global Leadership Initiative on Malnutrition proposed just a year and a little bit ago. So this is taking into account some new research, and they were specifically looking at sort of having one phenotypic and one etiologic criteria. So the phenotypic criteria are sort of unintentional weight loss, low BMI, or reduced muscle mass. So you'd have to have any one of those 3. And then the etiologic criteria, so either it has to be a result of reduced food intake or absorption, or underlying inflammation due to acute disease or injury or chronic disease. And so in particular, this accounts for disease states where people are still eating adequate amounts, but because of inflammation or because of other reasons, they're still not adequately nourished. So how common is malnutrition? Well, if you look in the literature, it's extremely variable. What we know for sure is that the prevalence rates are much higher in frail older adults. And of that sort of subset, they're highest in the rehab setting and in long-term care. So in other words, the more frail you get as you become older, the more chances that you'll have some difficulties with malnourishment at the best of times, and obviously can be worsened if there's illness that's exacerbated. Estimates generally in long-term care between 30 to 50%, but there are some estimates as high as 80%. And we've all seen it for sure if we work in long-term care facilities. And this is compared with 6% in the community, which is still higher than the baseline for younger adults, but is much more sort of in keeping with what we would expect. So how do we screen for malnutrition? So, the most common thing that we do is that we follow the weights of patients. And I already mentioned a little bit how you can fall into a bit of a trap with the weights, and it's not the be all and end all, but in many situations, it's a great way of sort of keeping track of how patients are doing. And so the criteria for whether a weight change is called clinically significant are on the screen here. So if it's greater than 2% loss within a month, or greater than 5% in 3 months, or greater than 10% in 6 months, then all of those are considered to be clinically significant. And generally, we'd be speaking about unintentional weight loss when we're talking about that. There are also many screening tools that are available. I've listed 6 of the more common ones here, just to, and all of these there's good evidence behind all of these, and there's sort of settings where, some of these may be favored over others. The Screen 2 is particularly good for screening older adults in the community, and there's lots of evidence behind that one. The MUST is an interesting tool just because if you don't have weight, they have alternate ways of being able to check for sort of surrogates of weight loss, such as arm circumference. So that tool is sort of interesting, and many people have sort of used that concept in research and in looking at malnutrition. And probably the gold standard, the one you see the most in the literature, the one that's the most robust, is the mini nutritional assessment, but it does take a little bit longer to do than some of the other ones, and it does have its deficiencies. But this is just sort of a copy of what the short version of the mini nutritional assessment looks like, and this one has 7 questions, and then you score it at the bottom. And there's a longer version of this one as well, but even the short version has a very good sensitivity and specificity associated with it in most settings. So why do we care about malnutrition in the first place? Well, it's very poorly tolerated in older adults. So it can impact a whole bunch of different things. It can in fact impact physical function. It can impact healthcare utilization. There's lots of data that shows that when people are malnourished, that their chances of them being in long-term care or in hospital or using ED resources and those kinds of things is greatly increased. And if someone's in hospital and they're malnourished, which is quite common because lots of people don't feel like eating when they're in the hospital, but that's associated with an increased length of hospital stay. So it's a very important issue for a variety of reasons. But interestingly, older adults are also much less likely to regain their weight after hospitalization. And so it's very important to do what we can to prevent the weight loss in the first place, because it's not like younger adults where they might lose a dramatic amount of weight during an acute illness, but then they put it back on again when they get better. Often older adults don't do that. So weight loss can be influenced by a variety of factors, and these are going to seem fairly obvious, but I'm going to talk through them in a little bit more detail. So the first is inadequate dietary intake, and that's probably the first thing that we think about. And that can be for a variety of reasons. One reason for that could be appetite loss or anorexia. And there's sort of, normal and not normal reasons why somebody might have appetite loss. But there are other reasons why someone may have an inadequate dietary intake. They may have sort of muscle atrophy or what's called sarcopenia, just from disuse or from other factors. We'll talk about that. But then the disease state itself may cause, hormone changes within the body, may cause metabolism changes that itself sort of uses up muscle and can lead to malnutrition. So often people think about malnutrition as being a vicious cycle, and I've borrowed this slide from Dr. Keller, who speaks on this, but essentially it's, if you have low or poor food intake, then that can lead to weight loss and muscle loss, which then in turn leads to poor appetite, which leads to poor food intake, and you can see how we keep going round and round. It's very important to try to break that cycle in as many ways as we can. So what are the ways that inadequate intake can sort of affect malnutrition? Well, the first is through various social things. So if somebody is socially isolated or if they have limited financial resources, then they just may not have access to food, or they may not feel like eating, because eating is a very social function. And when we're on our own, then we tend to eat less than when we're with other people. There could be medical or psychiatric causes. So depression is actually one of the leading causes of malnutrition in older adults. And in fact, is more prevalent than malignancy is. Everybody sort of thinks of weight loss and malignancy right away, but in fact, depression is even more of a problem. Dysphagia, or problems swallowing, that can be from Parkinson's disease or strokes or other neurologic problems, can obviously lead to difficulties. And then there's a whole bunch of other medical disorders, endocrine disorders, CHF, COPD, GI disorders, infections, rheumatologic disorders like rheumatoid arthritis, where you physically have difficulty getting the food and it may be sort of exhausting to feed yourself, or other neurologic conditions where you either can't move or you can't swallow, or other difficulties like that. Alzheimer's disease itself is strongly associated with malnutrition. Sometimes it's because of forgetting to eat. Sometimes it's because of neurologic problems that go with that. Sometimes it's access to food and resources, or knowing how to prepare that. So there can be a whole variety of reasons. Drug or alcohol dependence. So obviously if you're focused elsewhere, then you may not be eating, or eating a balanced diet. Medication side effects can also lead to decreased appetite. And then there's physiologic reasons, things that happen sort of as we get older, like our taste can decrease, or our stomachs take longer to empty, and so food stays there longer and we feel full for longer and don't eat as much. Or the actual hormones that are in the stomach themselves can change over time and lead to changes in terms of how hungry you are, and not feeling like eating. So anorexia, so obviously related to the previous topic of decreased food intake, but there may be some sort of appropriate or some normal times when people have anorexia. So for example, as we get older, then we may have reduced physical activity, and we may therefore have decreased energy needs, and our bodies tell us to eat less, so that can be sort of appropriate. Or as our bodies get older, we often our metabolism slows down, and we therefore don't spend as much energy, and so we may not need to eat for that reason. Or we may be losing muscle and we may be losing fat, and as you know, it takes a lot of energy to maintain the amount of muscle and fat that we have. And so as we lose weight, we in fact need less food in order to maintain what weight we've got, and so the body may naturally sort of tell us not to eat as much. But then when it comes time, when the body's under stress, or if we have disease states, then some of these appropriate changes that happen that tell us not to eat as much may in fact cause us to not eat when we should be eating. So any illnesses, drugs, dementia, mood changes can sort of further affect it. I want to say a few separate words about cachexia. We often talk about patients who look cachectic, or sort of wasted, and that's sort of something that we learn about in terms of our physical exam. The actual sort of definition of cachexia is a complex metabolic syndrome associated with underlying illness and characterized by a loss of muscle with or without loss of fat mass. So this is distinct from starvation. It's distinct from age-related loss of muscle, so sarcopenia. It's different than sort of psychiatric causes, and it's not from sort of, intestinal sort of malabsorption or endocrinological problems. It's caused by other sort of inflammatory responses. So cancer would be one sort of prime example, and we've all seen patients that have end-stage cancer and their muscle mass decreases and their fat goes down, and that's the situation where we sort of most often use the word cachectic. But we can also see it in end-stage kidney disease. We can see it in COPD. We can see it in heart failure, rheumatoid arthritis itself. There's lots of inflammatory responses, which is what causes all of the damage to the joints, but it can also cause, all of these complex changes that lead to loss of muscle. And you can see it in AIDS as well. And so if you think back to those patients, then you can probably think of situations where people sort of look very cachectic, despite the fact that they may be still eating appropriate amounts of food. And cachexia is of particular importance because it's much less responsive to treatment, and we have to be very proactive to make sure that patients have as much nutrition as possible, because the disease state itself is causing a lot of that muscle mass, so we want to maintain as much of it as possible, particularly around times of disease exacerbation, because if we lose it, then it's hard for it to come back again. And so all those patients that are in long-term care that are not being fed as much as they would normally, and there's not as much attention to giving them foods that they like and foods on a regular basis, and making sure that the food is warm and they have the same access to food. All of that sort of weight loss that's caused by that may never come back, because they may have these disease states that are causing other types of loss at the same time. Sarcopenia, which I mentioned several times, is a loss of muscle mass, strength, and performance. So it's caused some of it by disuse, but some of it by hormone changes like testosterone and estrogen changes that happen later in life, chronic diseases that cause muscle wasting, inflammation we talked about a little bit, insulin resistance, diabetes. And then if you're nutritionally deficient, then your body just takes muscle sort of in order to use it for energy and for nutrition, but then you lose the strength of that. There has been some suggestions that giving patients testosterone may be helpful, but generally we don't recommend it because the downsides are probably worse than the upside. But and there's no role for any other hormones like estrogens or anything else for sarcopenia. Maybe a small role of testosterone, but very controversial. The one thing that's very important is ensuring that there's adequate protein intake, as low protein can sort of exacerbate this problem. So how do we evaluate patients with nutritional issues? So the first is that we document if there's any weight loss, and then we evaluate their appetite and their dietary intake. Very important not just to ask patients how much they're eating and to have them give sort of a description of what they're eating or get a collateral source about that, but also very important to talk about whether patients are actually hungry and whether they're feeling about eating, because that can give you some big clues as to what the causes are for the problem. And then, like usual, we have to take a complete history, including sort of oral symptoms and looking for dental hygiene and those types of things, which can really impact, both taste as well as the ability to swallow and get food in, ability to chew food, all those types of things. And then we have to do a full physical exam, which would again include sort of an oral exam. And then there's a bunch of investigations that we can do, just looking for, things in the body that may not be right, that may cause us to not feel like eating, or problems in the body that may occur from sort of not eating enough. So some general blood work is often helpful. Chest x-rays and abdominal x-rays are less helpful, but they have been traditionally done, and a lot of people still do them. If we really can't figure out what's going on, sometimes we sort of look at the liver and do some additional blood work, and we look at sort of CT scans of the chest and the abdomen. But we reserve those really for patients where it's unclear what's going on. And everybody always sort of jumps right to wanting to have, colonoscopies, but colonoscopies are rarely helpful. Sometimes an upper scope, like an OGD, can be helpful if there's early satiety or early sort of sense of filling, of being full. but otherwise sort of often are not helpful. And usually, even if somebody had a colon cancer, you don't get sort of weight loss until very, very late stages when there's metastases everywhere. There's other types of cancer that are far more likely to sort of cause problems. So how do we treat it? Well, we ensure that there's adequate food intake, so lift any sort of dietary restrictions when possible, give whatever assistance is required, that may be for feeding or shopping or food preparation, make sure we're catering to the patient's individual tastes so that they eat as much as possible. We want to maximize the sources of protein, so not just carbohydrates to gain weight, but protein is extremely important, especially to sarcopenia as well as to bone health. Consider supplementation. This isn't the be all and end all, and it's certainly the last thing you should do, not the first thing you should do, but adding supplements can be helpful in certain situations. And everybody always wants to jump to appetite stimulators. And there's several out there, several medications that have been used for stimulating appetite, but in general, they lead to very, very small increases of weight, so usually between 2 and 4%, and often sort of clinically insignificant. And so we have to really weigh sort of, the advantages of a small amount of weight gain versus all of the side effects of those medications. Also consider sort of micronutrients in these patients to make sure their B12 is normal, that their vitamin D is normal, that they're getting an adequate amount of calcium in their diet, and if not, to supplement it. And multivitamins is a really controversial topic. There's no real clear evidence that they help, but certainly it's standard of practice that in patients that are chronically having an inadequate intake, we often give a multivitamin just because there's very little harm to it. But in patients that are eating well and have a balanced diet, then there's really no benefit to a multivitamin. So I just want to, in our last couple of minutes, spend a few slides on dehydration. So dehydration is caused by fluid imbalance from inadequate intake or excessive losses. So you're either not drinking enough or you're losing water somewhere. I've listed some symptoms here. We don't always see all these symptoms in older adults, or sometimes we see these symptoms present all the time, even when they're not dehydrated. And so it can be really difficult in an older adult to tell whether or not they're dehydrated or not. But certainly, reduced urine output can be sort of a clue, or just changes from what is the normal baseline. But just keep your wits about you, because dehydration is something that's easy to miss. And as I say, these symptoms may be present for many other reasons and not directly related to dehydration. There's several other things in older adults that kind of makes them even more likely to be dehydrated. For example, the kidneys are less sensitive to changes in volume, and so if somebody's hypovolemic or they don't have enough fluids, then it may take longer for the kidneys to kind of kick in and say, you know what, you need to drink more. Antidiuretic hormone, which is one way that the body uses to preserve fluid, the kidneys become less sensitive to it over time, and we also don't turn on ADH as much at night, which is one of the reasons why as you get older you pee more at night, because you're actually producing more urine at night, but then you also have a little bit more loss of fluid overnight, and you have to make that up during the day because you're peeing more and your body's not saying, you know what, I should concentrate the urine and not pee as much overnight. And then older adults, it also takes them longer when they're dehydrated to replace all of those fluids. So this is another slide that I borrowed from Dr. Keller, and just talking about sort of the sodium in the body and how that can give us some clue as to, how somebody lost their fluids or their volume. And so if the sodium is normal, then usually that's because somebody sort of had some vomiting or diarrhea or some quick loss of fluid, and it's usually pretty obvious clinically sort of what's happened. If the sodium is low, then often that can be from diuretics, because the way that diuretics or water pills work is that they actually cause your body to lose sodium, and then when you lose sodium, then the water sort of follows and leaves the body, and that's the way that diuretics work. And then in patients that just don't drink enough, or they've been losing it because of a fever or sweating or things like that, then the sodium tends to get too high, and that can be sort of our clue that that's what's going on in those patients. So how do we treat it? Well, really you have to think about what the reason is why they're dehydrated in the first place. So if they can't drink, then we have to sort of, if they're independent, sort of some education, give them sort of, glasses that have measurements on them, so in that way they can, have a goal as to how much to drink. If they forget, then just frequent offers, having it available to them, having tea times and times when patients would just naturally drink. If they're not able to swallow, then making sure that we're giving them foods that are sort of high in fluid, and that we're doing everything we can to get fluids in. Or using, if they're not able to physically do it, then just making sure that we're using a straw, which you wouldn't use for swallowing difficulties, but in other difficulties, such as getting the glass to your mouth and up, and things like that, we might use a straw. If they won't drink, then maybe sort of giving frequent small amounts during the day, or giving fluid with activities. If they're worried about incontinence, just education around it, or treating the incontinence. And if they're at the end of life, then just really thinking about whether or not having fluids is part of their goals of care, and it may be unnecessary, and they may in fact get more comfort from not having fluids and just letting nature take its course slowly. So I'll stop there, and happy to take some questions. I noticed in the chat box that there's already a question from Melissa about mirtazapine. So mirtazapine is a classic medication that we use to try to stimulate appetite. It's an antidepressant that has some side effects of causing increased appetite. So that's why we sometimes give it to those patients that are not eating enough. And it can also fix any mood problems. So if depression is one of the reasons why people aren't eating enough, then it may help to solve that problem at the same time. It also tends to make people a little bit tired, so we give it at night, and we sometimes use it as a sleeping aid. Mirtazapine generally, in patients that are malnourished, cause a very small amount of weight gain, and so I don't find it that helpful. Unfortunately, it tends to cause more weight gain in patients that are already overweight to begin with, and so it's very complicated in that sense, but we sometimes do try it, and I've had a few isolated cases of success, but definitely some cases where we've tried it and it hasn't worked, or the side effects have just not been tolerable. But definitely, what would be one of the first ones I would think about if we did feel like we needed to use a medication. So I see that Dawn has shared a COVID editorial, so thank you for that, and everybody can take a look at that. And then we've got another question: share thoughts on the etiology behind dehydration. Is there any physiological reasons or illness sort of impacting hydration needs? And so, I mean, generally speaking, the interesting thing is that, a lot of our water intake comes from food. So, so malnutrition and dehydration are somewhat linked in that sense. Anybody that has sort of chronic diarrhea or chronic losses, definitely, are always at risk of dehydration. So a classic patient in that situation are patients with colostomies. Their bowels empty into a bag that's been surgically sort of a stomas or a sort of outlet has been put on their stomach. So in those cases, they can have a lot of losses. Sometimes when people are malnourished in general, then they have more difficulty sort of managing fluids and can have chronic diarrhea or kidney problems. And then there are some disease states like diabetes insipidus that can happen from lithium use, and there's other reasons, sort of endocrinologic reasons, why you might sort of pee more than you're supposed to, and the kidneys, might not hold on to as much water as possible. But those are all more rare causes. I think by far the biggest cause is just that people don't drink enough just because they forget or don't have access, or are scared to drink, or those types of things. And CBD oil to increase appetite and mood. So I'm definitely not a CBD expert, but we do have another geriatrician who works in our area, and she has had some consults around trying to induce appetite through CBD oil. Not great research showing that that has a huge effect, and so it's not sort of the magic cure that we've all been waiting for, but definitely. Definitely we see, definitely when we're desperate, if we think that somebody can tolerate it and we think that, that we would look at trying it. And then just like Tamara is saying in the chat box right now, the THC component of cannabis tends to cause more appetite gain than CBD, but the THC component tends to also cause more neuropsychiatric effects, and so often the component of cannabis that we're avoiding in older adults, and so that can sometimes limit its use as well, but definitely something that we do look at, and particularly sometimes giving it timing when we give it, and being very careful with it. So, and thanks Tamara for that additional comment. So I think that's what's come up in the chat box. Anything else, Allison, or have I covered it all?
I'm not seeing anything else in the chat box. You're so much better at this than I am watching the chat box and presenting at the same time. So thank you so much.
That's great. Well, thanks everybody for your attention, and that half an hour went by very quickly. So so that's great. Thanks everybody, and keep safe. Have a great long weekend.
Thanks everyone. Bye-bye.